Hi friends, in this video we will be discussing about some important respiratory disorders in children. So first, some basic differences that differentiate the pediatric airway from the adult airway. So we know that the pediatric airway, in children there is a large head, okay. So children have a large head, short neck and a large tongue, making their airway very difficult. I am sure the anesthetists will agree with me. So they have a large head, short neck and a large tongue, proportionately large tongue they have, okay. And the position of the larynx is more anterior and cephalad in them. So larynx is more anterior and cephalad in infants and children, so more higher in position, okay. The epiglottis is relatively long and floppy and U-shaped. So epiglottis is more longer and floppy in infants and young children. The carina is at the level of T2, unlike T4 in adults. So in children the carina is at the level of T2. And the narrowest part of airway in children, which was previously believed to be at the level of cricoid cartilage, now it is believed to be in the supraglottic area, okay. So the narrowest part, so this is a controversial topic, but the narrowest part of the airway in children is now believed to be in the subglottic area, okay, in the subglottic area. Previously it was believed to be in the cricoid area, cricoid cartilage area, but now it is believed to be in the subglottic area, okay. Now discussing a little bit about some of the congenital malformations of airway. So one of them is laryngomalacia. So this laryngomalacia is the most common cause of stridor in infants, okay, most common cause of stridor or noisy breathing in infants. And this stridor exacerbates on crying or on feeding. So exacerbates on crying or feeding, okay, or when the child is agitated. But it decreases when the child is placed in the prone position, because due to gravity the airway is kept open, okay. So decreases in prone positioning of the baby, okay, in prone position. The symptoms usually appear in the first 2 weeks of life. The symptoms usually appear in the first 2 weeks of life and may increase in severity up to 6 months. So symptoms usually appear in first 2 weeks of life and may increase in severity, up to 6 months, and then it might resolve spontaneously, okay. The diagnosis is confirmed by flexible laryngoscopy. So diagnosis is confirmed by the flexible laryngoscopy, where you get the omega shaped epiglottis, okay. So this is what the omega shaped epiglottis of laryngomalacia looks like, okay, omega shaped epiglottis. Usually no treatment is required and it resolves spontaneously, just supportive care, okay. Moving ahead to some congenital malformations of lung. So pulmonary hypoplasia refers to basically defective development of one or more lungs, okay, defective development of one or more lungs, and of course it is a severe condition, okay, of one or more lungs, right. What do you mean by pulmonary sequestration? So sequestration means one isolated area. So pulmonary sequestration are discrete areas of lung tissue that lack any connection with the airway system. So they are those isolated areas in the lungs. So pulmonary sequestration refers to discrete areas of lung tissues that lack any connection with the airway system. So what will happen? The secretions which are generated there stay there only and they are not drained out, and it becomes a focus of infection. So there is recurrent pneumonia in these children, okay. So discrete areas of lung tissue that lack any connection with the airway system, And we know normally the lungs get blood from the pulmonary artery, but these areas get abnormal blood supply from aorta, okay. So these areas these areas get abnormal blood supply from aorta. Okay, blood supply from aorta. There are two types of sequestration. What are they? The extralobar type and the intralobar type. Okay, extralobar and the intralobar type of sequestration. So let us see what are the differences between them. So the extralobar type is present external to the lungs. Present external, their location is external to the lungs. While the name itself tells you the intralobar type occurs inside the lungs. Occurs inside lungs. Okay. And the manifestations of extralobar type is basically due to compression of the lung. Okay. So due to compression of the lung. So by mass effect it manifests. While the intralobar type manifests due to localized infections or bronchiectasis. Okay. So manifests due to localized infections or bronchiectasis. Okay, bronchiectasis. The venous return of the extralobar type is through IVC, while the venous return of the intralobar type occurs through the pulmonary veins, just like the lungs. So these are the two important types of pulmonary sequestration that we need to be aware of, which can be a focus for, recurrent pneumonias, right? Involving the same areas. Now, congenital lobar emphysema is another important congenital lung malformation where there is overdistension. Okay, so overdistension of one or more lobes of the lungs. Overdistension of one or more lobes of lung. Most commonly involved lobe is the left upper lobe. So the left upper lobe has been seen to be most commonly involved. Most commonly involved. So there is overdistension of the left upper lobe. So the ipsilateral normal lobe gets compressed. Okay, so compressed. So atelectasis. So compression causes atelectasis or collapse. So atelectasis or collapse of the ipsilateral normal lobe. Ipsilateral normal lobe. And of course, there is mediastinal shift of the overdistended segment. Okay, so there is mediastinal shift of the overdistended segment as well. It may present in the neonatal period with tachypnea, dyspnea and cyanosis. So may present in the neonatal period with tachypnea, dyspnea and cyanosis. Okay, and surgery may be required in symptomatic cases. So for the treatment, surgery required in symptomatic cases. Right? So this is what a congenital lobar emphysema looks like. So you can see a overinflated left upper lobe here. So this is the overinflated left upper lobe and this is the collapsed ipsilateral normal lobe. Okay, and you can see the mediastinal shift here. So this is a typical example of congenital lobar emphysema involving the left upper lobe. Right? Now moving ahead to a little bit about congenital cystic adenomatoid malformation. The new name for this is CPAM or congenital pulmonary airway malformation. Congenital pulmonary airway malformation. Airway malformation. Right? The basic defect is there is hematomatous or dysplastic lung tissue. Okay, so hematomatous or dysplastic lung tissue which is usually confined to one lobe. Hematomatous or dysplastic lung tissue usually confined to one lobe. And it usually presents in infancy with respiratory distress, recurrent respiratory infections, and even pneumothorax can occur. So, respiratory distress, recurrent infections, and even pneumothorax can occur, okay, because cystic areas are there which can break down to cause pneumothorax, okay. So, the chest X-ray and CCAM, can you appreciate these cystic shadows in the lungs here? The cystic shadows are there. A close differential diagnosis of this condition would be congenital diaphragmatic hernia. But remember, in congenital diaphragmatic hernia, there is a diaphragmatic defect. You cannot appreciate the outline of the diaphragm on the side of hernia. But here you can clearly appreciate the diaphragmatic outline here. So, this is a chest X-ray in CCAM. Okay, the cystic shadows which you can see unilateral and the diaphragmatic margin is intact. And here also again surgery is required in symptomatic cases. So, surgery in symptomatic cases. And congenital diaphragmatic hernia is a close differential diagnosis of this condition, right? So, moving on to a little bit about foreign body aspiration in children. So, the most common age group involved is the infant and the toddler age group. Okay, so 1 to 3 years is the most common age group involved, and the most common objects are some food items like peanuts and corns and some small toys and balloons. Okay, toys, balloons. Okay. The most serious complication can be complete obstruction of the airway. Okay, if something goes and lodges in the airway and there is a complete obstruction of the airway, that can be a serious complication. Okay. The clinical features of foreign body aspiration, the initial event is going to be an episode of choking. Okay, violent coughing, choking and gagging. So, violent coughing, choking and gagging, okay, immediately after the intake of some food item or some item inside the mouth, okay. So, immediately after the intake, okay. Then there is a asymptomatic interval when the foreign body becomes lodged and the reflexes get fatigued and irritating symptoms subside. So, there is a asymptomatic phase when the foreign body gets lodged, reflexes, fatigue, and the irritating symptoms subside. But the child can develop, can continue to have respiratory distress, cyanosis, and so on. Okay. So, complications of foreign body aspiration, one we said the complete obstruction of airway, which is a fatal complication, most serious. So, complete obstruction of airway, and that will give rise to atelectasis, and this is the most serious complication we said. Erosion of the bronchus can give rise to hemoptysis. So, erosion of bronchus can give rise to hemoptysis, and secondary infection can give rise to fever and cough again. So, secondary infection can give rise to fever and cough. Okay. So, these are the complications of foreign body aspiration. The diagnosis is by the typical case scenario: sudden onset choking and violent coughing and a new onset wheezing, unilateral lung findings in a previously well child. And you can see if you do a chest X-ray, you can get unilateral hyperinflation. So, unilateral hyperinflation and unilateral lung findings point towards the diagnosis. The X-ray may sometimes be normal in 15 to 30% cases, and opaque foreign body may be found in 10 to 20% cases. So, chest X-ray may be normal in 15 to 20% cases, and sometimes opaque foreign body seen. So for the management, we will do a chest x-ray to confirm our diagnosis, and we will do a urgent removal of the foreign body by rigid bronchoscopy. So urgent removal of foreign body by rigid bronchoscopy. Okay. So that is how we manage this condition, and on this also there was a recent question in the INI CET November 2022 exam. So a case scenario was there in which there was a foreign body aspiration, and what do you do next? So we will do a chest x-ray and a rigid bronchoscopic removal of the foreign body. So very important, must know topic for you, right?